everyone. Welcome to the Antibiotic Stewardship Collaborative. This is Julie Aples. I'm the Vice President of Quality and Performance Excellence at Leading Age, Minnesota. Before we get started here, I just wanted to spend a few minutes to talk about the goals and components of the program before I turn it over to the University of North Carolina team. So Kimberly, would you mind advancing the slide? Thank you. So, and just a reminder too, if you have any questions throughout the session here, you can go ahead and type your questions or comments in the question or chat box. So please feel free during the broadcast to send any questions that you have. So the main goals of the collaborative, the first one that we've talked about is to meet the requirements of participation. So there's a number of requirements that will begin in November. And then also, probably even more importantly, is to understand the antibiotic use within your organization and to improve your performance on the use of antibiotics. Next slide. The program components, the one we're going to talk about quite a bit today is data collection and analysis. And then there'll be opportunities throughout the collaborative for education and training. And then we're going to be using the data and analyzing the data to provide support for targeted improvement in what we identify within the data. And then opportunities for learning and sharing with your colleagues. So we'll have opportunities for conference calls, and we're also going to be setting up a listserv, and then just sharing learnings and tools throughout the collaborative sessions. Next slide. So I'm going to go ahead and introduce the UNC team, and you see their lovely pictures here. And to introduce Dr. Philip Sloan, he is the Elizabeth and Oscar Goodwin Distinguished Professor of Family Medicine at the University of North Carolina at Chapel Hill. He is jointly certified in family medicine and geriatric medicine. He has served as medical director of a skilled nursing facility, medical director of an Alzheimer's unit. He's a national advisor in Alzheimer's care for a major nursing home chain, the director of a nursing home teaching service, and physician and quality consultant to a program of all-inclusive care for the elderly. As a researcher, he's conducted over 20 studies in nursing homes and assisted living, including studies in antibiotic stewardship. And then Kimberly Ward is a project coordinator for the program in aging, disability, and long-term care at the Cecil G. Shep Center for Health Services Research. So I am going to go ahead and turn it over to Dr. Sloan and Kimberly.
Hello, this is Dr. Philip Sloan. Julie, I hope you're on and you will let me know if you can't hear me.
You sound great. I can hear you.
Great. All right. So I'm going to advance a slide here, and thank you all for joining this. We're really looking forward to working with you. The idea of a collaborative is a fantastic one, and Julie gets credit for that. But I think making any kind of policy and practice changes within long-term care is not the easiest thing in the world, as you all know. And so kind of working together can help all of you make more headway and feel like you're not alone. And we're looking forward to it because this is exactly the kind of thing we'd love to see replicated elsewhere in the country, because it's really the way to help change practice. So we're going to be talking about just getting started with this collaborative and some of the things that we need to know just getting started. So I'm going to talk about three main things. First of all, kind of give you a pep talk about why antibiotic stewardship and why it is important. And then next we will talk about the CMS mandate for nursing homes to implement antibiotic stewardship, what they put into the Federal Register, what they put into the regulations, and sort of, because obviously we have to address those. And then we're going to get real practical in terms of steps you can take to develop an antibiotic stewardship program in your nursing home, and how the materials that we have provided will hopefully help make that easier and more consistent. So we started out by kind of make sure we're all on the same page about why this is an important thing. And I'll tell you the truth, man, I hadn't heard about it until maybe 6 or 8 years ago. I think it's something that's just gotten on the radar screen of most people, although a few people have been interested in this for a long time. So, and I'm sorry this is a wordy definition, but antibiotic stewardship it's a set of commitments and activities designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. Another way to put it is to say it's a system of informatics, meaning kind of data systems, data collection, personnel, policies, and procedures designed to assure that your residents get the right drug at the right time for the right duration. And that way we avoid, as much as we can, adverse effects from unnecessary treatment. So the next thing to think about is, well, why are people talking about this now, and why weren't they before, and why is it important, first of all, for society, and secondly, for nursing homes? Why are they picking on nursing homes? Now, of course, those of you who've been in hospitals probably know they've been doing this in hospitals for at least 5 or 6 years. And so the next place that this is being applied is nursing homes. And there are reasons for that. But let's kind of look at the world view. There's just a lot more antibiotic resistance than there used to be. And when penicillin came out, when sulfa came out, they would take care of everything. And then we got penicillin resistance, and then we got sulfa resistance, and then we got other things, we got amoxicillin, and then we got resistance to that. And we keep coming up with these antibiotics, and then the bacteria are smart and they keep getting resistant. And we have a crisis now because we're running out of antibiotics, and the resistance is developing more quickly than it used to. So that people look ahead, and this map is from a JAMA article that predicted if things continue the way they are, how many deaths will there be from antibiotic resistance in the year 2050? And essentially they're talking about something like 10 million deaths per year from antibiotic resistance, a lot of them in Africa and Asia where antibiotics are especially overused. But to go from the 20,000 we have now to 317,000, that's a big jump. So people are worried about this. In fact, this is from the British, from BBC in Britain, and they asked a bunch of futurists about what are the biggest challenges we need to work on as a society, global problems such as climate change or poverty. Number one that came up was how can we avoid resistance to antibiotics. So it's kind of a big deal, and we're all kind of part of that, and nursing homes, for reasons I'll explain as we go on, have a particularly important role in it. So it's reasonable to ask, well, why is this all of a sudden a problem? And there are 3 reasons. First of all, the drug companies are making fewer antibiotics. You can see how many in the 80s, how many in the 90s, and it's trickling down to almost nothing nowadays. And the reasons for that are, first of all, it costs about 10 times as much as it used to get a drug through the development process all the way to having it out in circulation. So it costs a lot of money. Secondly, when antibiotic comes out, the first thing people want to do is not use it. They want to save it for resistant infections. And so it doesn't get sold very much, and it's only used for maybe 10 days or 14 days. And so it's not like something like a cholesterol lowering agent, which people will use for years. And so the profit margins aren't very good. There are some efforts being made at the government level to stimulate development of new antibiotics, and hopefully we'll see some of the fruits of that in the next decade. But right now we have to deal with the fact that what we have is what we're going to have for at least a few years and maybe for a while. And so we have to take really good care of the antibiotics that we have. So the second thing that's causing the crisis is that people move around. And so once a resistant bacterium emerges, pretty soon it's in different cities, different states, different countries, because people move a lot more than they used to. This is particularly true because some of the worst resistant organisms develop in places like India, where there's medical tourism, and people will go to usually a hospital in India. They'll get treated, and they'll get a resistant bug, and then they'll go back to Sweden or England or wherever they go back to, and next thing you know, it's spreading all over the world. We can't do much about either of these things, but the one thing we can do something about is antibiotic overuse. And it turns out that hospitals provide more antibiotics than any place else, but nursing homes are number 2, And the thing about nursing homes that makes them unique is that people stay for years. So if a hospital gives high-dose antibiotics and creates resistance, the people go out of the hospital into the community or into the nursing home, and then they stay there. And then in the nursing home, of course, you go from room to room, and people move around and touch each other, and it's impossible to completely halt the spread of infection. And so resistant organisms are quite prevalent, even to people who aren't sick in the nursing home. Here's something from the New York Times from 2014 that to me was just a particularly poignant example of what happens when antibiotics are overused. So in India, they found that the year before, 58,000 infants died of resistant infections. And this is like 3 times as many people as everyone who dies of infection in this country, of resistant infection. And the reason? They thought it was a good idea to give an injection of a strong antibiotic, was probably something like ceftriaxone, to every infant to try to prevent infections. And what happened was they just made a lot of resistance, and now they've got essentially an epidemic of resistant infections. The same kind of thing can happen to us if we overuse antibiotics for specific things, and it does happen. So, and just to prove it, this came out last year. The superbug that doctors have been dreading just reached the United States from the Washington Post, and there have been some other case reports since then about people who have strains that resist to every last antibiotic. And this was a 49-year-old woman, but when you look at her history, it's clear she was like a nursing home resident. She had multiple UTIs. She'd been in the hospital multiple times. She had chronic disability. And so the kind of person that we see a lot in nursing facilities. All of which is to say, this is a problem and something worth thinking about. So the next question is to bring it down to the nursing home level. And these are data from 31 different nursing homes where we went, and just as you are about to do, we looked at their antibiotic prescribing and then calculated their rate of prescriptions per resident per year. Now we're going to use per resident per 1,000 days because that's what most folks use, but this, I can understand this better, and we can obviously do this for you as well. But you can see nursing home A prescribed on average 9.5 antibiotic prescriptions per resident per year. And then this goes all the way down to the one on the very right, EE, prescribed about 2.3 prescriptions per resident per year. That's a huge difference, but that's a lot of antibiotics. And what it means is that on average, the average nursing home resident gets 4.6 antibiotic prescriptions per year. That's 1 prescription every 80 days. And it means that they're on antibiotics about 10% of the time. That's a lot of exposure. Now, this is not telling you anything you don't already know. The most common reason antibiotics are prescribed, UTI. I said here presumed UTI because, as we will learn, some of these folks don't have real infections. And so that's why I say presumed. Now, respiratory infection is number 2. And I say infection because they always have an infection with something. Sometimes, however, it's a viral infection for which an antibiotic is probably not needed or helpful. And then I say presumed skin and soft tissue infection because, as we'll learn in the education as we go on, pretty often people get antibiotics when there's really not an infection or the kind of infection that needs systemic antibiotics. The area that's growing the fastest is other infection, and ironically, the most common other infection is C. diff, which of course, as you all know, is a complication of antibiotic use. So this is the kind of playing field on which we're going to try to make some changes. And that's behind the CMS mandate. CMS is thinking, we have to do something about antibiotic resistance. Let's look at nursing homes where a lot of the particularly difficult resistance develops, and let's see what we can do. And so they have mandated this antibiotic stewardship program. Now, here's a lot of words. These are from the Federal Register. These are actually from the regulations. And they didn't really say that much about specifics, but what they say is, we are requiring facilities to develop an infection prevention and control program that includes an antibiotic stewardship program and designate at least 1 infection preventionist. That program should include antibiotic use protocols and a system to monitor antibiotic use. And they have an implementation timetable, which you're probably aware of, antibiotic stewardship by this November. And then an infection preventionist, which we'll talk about in a little bit, the following year, and the infection preventionist on the Quality Assessment and Assurance Committee, that November 2019. So what is this infection preventionist? And we're not exactly sure. We think it's going to be your infection control nurse who just will have to have certain mandated training, which will get developed over the next year or so. You will be way ahead of the game just by virtue of having done some of these things. So this is a policy change. It really is a difference. And in addition to a policy change, it's really a change in the way we think about things. Because when I was trained, and probably when many of you were trained, we really felt, well, just give an antibiotic just in case. You know, it might help. And if we're not sure, give an antibiotic. But now, because of this antibiotic overuse in these resistant infections, we have to think antibiotics should be given only after careful evidence-based consideration of risks and necessities. So in a way, it's going from just in case to only when needed. And so we're, in this session and further on, we'll provide guidance on key elements of antibiotic stewardship for your nursing home, how to implement these CMS regulations. Now, the surveyors already have F-tags. In fact, over the past year, one of the goals for CMS was to develop and pilot test measures that the surveyors can use to cite facilities for not meeting the antibiotic stewardship requirement. And they will use most likely F-tag 441 infection control, but then some of these other ones that they could use include 329 unnecessary drugs, or the medication error one, or even the one around drug regimen review for certain things that they are trying to discourage. So it's coming, and we just need to be prepared for it. Now here's an interesting thing. This is data from 2014 on what were the most common nursing home deficiencies. You can see the number one deficiency already is infection control. Now here, most of this was about the kinds of things you're aware of, like hand washing and hygiene between between rooms, and what happens in the kitchen and this kind of thing. They're going to add this whole other layer about drug prescribing and drug use that is going to be part of the infection control survey. So surveyors are going to spend a lot of time looking at infection control. Now, I have to be honest, in the best of circumstances, antibiotic stewardship only works sometimes. And we've done several studies and that can show it can work, and some we have evidence that shows it's not the easiest thing to implement. So this was the first study. This was a randomized controlled trial we did in 7 nursing homes and 7 control homes. And what we found was that we were able to reduce by 24% the antibiotic prescribing rates in our intervention nursing homes without a single episode, a single incident where somebody had hospitalization or got worse or died because an antibiotic had been withheld inappropriately. So we feel pretty confident we can say you can reduce by a quarter in most situations your prescriptions without seeing any bad effects. Of course, we're going to want to monitor for that. Now, one of the interesting things is just by telling the control facilities that we were looking at infections, they reduced their prescribing by about 8 or 9%. So you're going to be at an advantage just by starting to shed a light on it, and that's one of the reasons why we would like to have you collect your data before we get all this stuff started, because you're going to change and in a positive way just by starting to talk about it, and then your education will help even more. Currently, we've recently finished 2 years of a study in which we wanted to ask ourselves which is a better way to go about implementing antibiotic stewardship, going through the physicians or going through the nursing homes and nursing home administration. And interestingly, we found that we were a little more effective doing what you're doing, which is putting it in place at at a nursing home administrative level and building it into policies and procedures and bringing on board the medical folks. In both of these parts of this study, however, overall we were able to effect significant change. Total antibiotic prescriptions down, you can see, 16.7%. UTI prescriptions down 26%. Respiratory infection prescriptions down 21%. We didn't much have impact in skin infection prescriptions. At the same time, the hospitalizations were down a little. Readmissions within 30 days were down 41%. Now, we're not taking credit for the hospitalization rates and readmission rates going down because we know everybody's trying to do that. But we certainly didn't make it more difficult for them, and maybe we contributed in some way to this as well. So we feel pretty good about these data, but when you tease it out, and this is what's really interesting, and this is what this next slide shows, what we found is that some of the nursing homes did a really good job, and some of them really didn't change at all. So if you go from left to right on this, number E on the left, yellow was what their rate was before we started the project. Okay, it was 10.8 prescriptions per person, and this was per year. And look at how far it went down. They were stellar. They really got on board. Everybody was into it. J, the same kind of thing, high rate at the beginning, low rate. But then look at the third one, H. They had a pretty high rate, and 6, almost 7 prescriptions per person per year, and they went up. And as you go through this, you'll see some of them went down, some of them went up. I don't worry too much about the ones that had really low rates and went up a little, like the one way in the end. But the reason for this is that there was traction in some and not in others. The medical staff were on board. The administrative staff were on board. The nursing director was on board. The administrator really made sure everybody got educated. The infection control nurse took a leadership role, didn't turn over. There weren't gaps when there was nobody in infection control for months. And these are the kinds of things over which you have some control and over which nobody has total control, but clearly what you do and how you do it is important to what you get. So we'll look forward to seeing how we do, because I mean, we're all in this together. And one of the things we're going to do is spend quite a bit of time, especially in June, talking about specific problem areas and setting targets for your antibiotic stewardship program. And we want to be informed by information you're going to give us about some of the audits you'll be doing over the next few weeks, because, and Kimberly's going to talk about it in a minute. We want to be data-based. You know, this is quality improvement, really, and you have to know where you start and what you're doing and kind of what you want to change. And you'll want to individualize things depending on what your goals are, and that's what we'll be talking about in June. For now, we're going to talk more in general about the program and how to make your first steps on it. So, how to develop an antibiotic stewardship program in your nursing home. Moving pretty quickly, that's good, hopefully, because you're all busy. So you all have these toolkits, and we just want to take some time and talk about what you've received, what it contains, and then how to get started. There's an implementation manual. We have training materials for the nursing staff. We have training materials for the medical staff. We have instructional materials for residents and families. We've given you a CD-ROM for emergency department medical staff training and some infection tracking Excel spreadsheets. Kimberly and I are going to go through each of these in the next few minutes. The first, the implementation manual, and we'd be happy to get feedback on this because this is something that really you'll be among the groups of people who are using it for the first time. It's really a step-by-step guide explaining how facilities like yours can incorporate our materials into a program that will improve outcomes. It's trying to put into place the kinds of things we've done before in other homes, but this is kind of putting you in the driver's seat. So the first thing to do is make a commitment. You know, commit your leadership, create a team. You've done a lot of that, but Just want to reinforce this because of what we saw about the differences between the different homes, all of which agreed to be part of our project. Agree to incorporate antibiotic stewardship into your quality assurance and performance improvement goals. If it becomes part of your quality plan, then it's really part of your kind of essential quality management, which is important. You'll want to identify an infection preventionist. This is probably your infection control nurse or infection specialist, whatever you call it, and provide them time. What we found when we surveyed a bunch of infection control nurses, and we found everybody wears more than one hat. And I don't think we found a single person who that was their full-time job. And they would be a DON or ADON or have some other role. And on average, it was what, 5 hours per week that they actually got to spend on infection control. I think CMS would like to see that increase, and if you could figure out a way to increase it so the person really has some time to not only gather the data but look at it and think about things and work with other people, it'd probably be helpful. Kimberly can talk more about that. She's communicated on a monthly basis with some of these infection control nurses and kind of knows what works and what doesn't. And we'll be talking about those as we do our monthly check-ins as part of this collaborative. And then you want to set up a antibiotic stewardship leadership team that includes the infection preventionist and then a few other people. We'll talk about that in the next slide. And then communicate expectations that this is going to be part of what we're doing, and we want to see how well we can do at this. Make it a challenge for folks. So this is what the Centers for Disease Control and Prevention, CDC, says they recommend to be part of an antibiotic stewardship team. Medical director, director of nursing, your infection preventionist, and a consultant pharmacist. Now, if you can get that group together once a month, you're doing pretty well. It may be only once every 3 months that you can get this group together. And so clearly, someone has to take the lead on a day-to-day basis, and hopefully it will be the infection preventionist, but also if the DON and the medical director could be part of it, and depending on your consultant pharmacist, if you all can meet on a monthly basis, I think it really would be helpful. And then the bottom there, your laboratory can provide you with certain data that may be useful. And if you've got an infectious disease person, let's say at a local hospital or local medical school who is interested, that you can curbside every once in a while with questions, sometimes that can be helpful. And you have to be careful. Sometimes their advice just is not practical for the nursing home setting. And something we found, when we deal with recommendations from experts, sometimes they just, if they're hospital-based, they just don't really understand that the nursing home is a different world. And so you have to use your common sense in getting advice from anybody, but certainly having a team of folks that you can work with and that can talk these out will be really helpful. Once you've got your team, you want to set goals, set your timetable, and Julie's going to be talking about timetables for this collaborative around data reporting, education, quality improvement reports. These are all things we're building into it. Your involvement in collaborative meetings. And then one of the first steps, I think, will be to gather your 3-month statistics so you'll know where you're starting with your leadership team and setting initial targets. So in order to be able to do that, you kind of have to gather your 3-month statistics. And that's what we're going to talk about next. The reason to gather data is because we want to change things. We want to change outcomes. And among the outcomes we want to change are minimizing the unnecessary antibiotic prescriptions, and we'll measure them in prescription per 1,000 resident days. And another thing that turns out has become, we talk about this more, an important measure because we can actually do quite a bit about it, is the percent of time on antibiotics. And I want to talk about this for a minute because the way I used to think about it is the longer you kept some antibiotics, the more likely you were to get rid of any resistance in the organism you're trying to treat. And that seemed to make sense for years, but what people have found out is when you do that, the main thing you do is create resistance in all the bacteria that are in the bowel and other places that you're not trying to treat. And so you generate more resistance by long courses of antibiotics than by short ones. And so now what the experts are recommending, which is different than what I learned, is just give an antibiotic for long enough to get the infection under control and then stop it. And so that means that people are really looking carefully at shorter courses for pneumonia, shorter courses for UTI, shorter courses for skin and soft tissue, and that's the harder one because we don't know as much about that. And so percent of time on antibiotics is kind of one of the new things that experts are talking about, and we've incorporated some of that into some of our training. Obviously, another measure, a clear one, is C. diff infection rates, and over time, we ought to see those go down, although admittedly, the majority of C. diff cases come because people are treated in the hospital, and so we don't expect a lot of change in that, but we'd like to see some. Another thing we can look at is urine cultures, and we'll talk about that later because you have to get them from your lab and you got to process them, and it's kind of a pain in the neck to do, but certainly seeing the resistance rates in your cultures is a useful thing to look at. And then of course you want to make sure you're not doing anything wrong or having bad events. So we like to look at hospitalization for sepsis and hospitalizations in general, because if they're going up, then we've got to look at it real carefully. And then there's some process measures that we're probably not going to look at right away, but some other things to be looked at further down the line. So lots of things that data can do to help identify areas and compare yourself with other nursing homes and with yourselves. But you have to have the data to do that, and so I'm going to turn this over to Kimberly, and she's going to talk you through the Excel spreadsheets that we've provided.
Hi everyone, my name is Kimberly Ward, and I'm just going to kind of walk you through the spreadsheets that we developed for you to track your data. In your packet, you should have gotten a flash drive, and in that there's an Excel spreadsheet for 2017. You'll also see another one for 2018, as well as 2 PDFs of paper forms that you can use if you'd like. And that would include this monthly summary information as well as a way to track your antibiotics on paper. Some people prefer the paper, and what they'll do is they'll just fill the paper forms out and then enter those electronically. You can do whatever works for you. I also included an example of what yours should look like once it's completed for 2017. So it'll show you what one looks like that's been filled out. That way you can see what this will look like once you've done it. So just to kind of get started, I'm just going to walk you through kind of basically the information that we're collecting on a monthly basis. I don't want you to panic. We don't think this should take you any more than 4 hours a month to do, and that's for a larger nursing home of about 120 beds. So if you'll see on this first screen, what we're going to ask you to collect on a monthly basis is your average census for short stay, your average census for long stay, the number of urine cultures that you receive each month, the number of residents who are treated for C. diff, the number of residents who are treated for MRSA, the number of residents who are hospitalized overnight. So these are not people who go to the emergency department, but people who are actually admitted to the hospital. And then of these hospitalizations, the number that were readmissions within 30 days. So you're just entering the number of residents in each column for that month for each one of the people that kind of fit this. You'll also see down at the bottom, there's a bunch of tables, and I'll explain those in a minute, but they're just going to track some statistics for you. So if you see that box underneath each column, it'll say enter antibiotics for that particular month. So I'm going to kind of walk you through what that form looks like. So if you were to click on that, it's going to open up a form that looks like this, that has a way for you to track your monthly systemic antibiotics. And this is only systemic antibiotics. We want you to exclude any topicals, antivirals, and antifungals, just systemic antibiotics. It's probably easiest if you complete this weekly instead of monthly. That way it'll just take you a little bit less time and you're not having to pull your records if you're having to go back for an entire month. And so if you'll just see in the first column, we just want you to put in your start date of antibiotic, and that's just kind of a day, month, year format. You'll notice in your Excel spreadsheet it'll kind of force you to enter that format. The name of the antibiotic, the duration, so the number of days the antibiotic was prescribed for, the resident name, and you can use first name and last name, or you could just use their initials. It's really your preference. room number, and we just, you can include room number because some of your residents might have the same initials or, same last name, or, it might just be easier to include room number. The reason the antibiotic was prescribed, so this would be urinary, skin, respiratory, other, and then you might even have an occasionally not documented reason, and that's all in the drop-down menu, as you guys will see once you open it up. And if it was for another reason, we just ask that you state the specific diagnosis. So, one of the more common ones is, C. diff. So, that would be coded as an other, and you would just, enter the specific diagnosis there. Oh, and if there are two, it's a single antibiotic prescribed for 2 infections. We just want you to enter the most dominant reason. And so in that, if there was a secondary diagnosis, you would enter that into other. And we've outlined all of this stuff in the implementation manual. So, if this is seeming a little bit fast for you, just know that it's completely outlined for you there so that it's not as confusing. We also want you to enter where it was prescribed. And so this is either the nursing home, the emergency department, the hospital, or an outside medical provider's office. And if it was prescribed in the nursing home or a medical provider's office, we want you to enter the prescriber's last name. And this will be a way for you to track who your common prescribers are. If it was done in the emergency department or the hospital, you won't be able to track likely who actually prescribed the antibiotics. And if you see this little button on there, it says back to the main page. Once you click that, it'll take you back to that summary page that we were on. So here's an example of one that I filled out for one of our nursing homes in our study. They're likely very similar to your type of nursing home. And as you'll see here, this is our January, February, and March data that we have for them so far this year. This particular nursing home doesn't do a lot of short-term rehab, so you'll see that their average census for short stay is 0. Then their average census for long stay, 76. They had 5 urine cultures. 0 residents were treated for C. diff. They had 1 treated for MRSA. 5 residents were hospitalized overnight, and 1 of those was a 30-day readmission. Yeah. Just urine cultures for that. And here's where they've entered their antibiotics for March of 2017. So you'll just see basically, you'll see the start date, their name of their antibiotic, the duration, the reason the antibiotic was prescribed. You can see all the reasons here. And particularly for their other one, you'll see that they prescribed it for someone had an elevated white blood cell count. But that was not, they didn't have any more specific data for that, so that's how they entered that. Where the antibiotic was prescribed, and who the prescriber's last name was. And you'll see on here, I actually left out resident name and room number just because I was trying to keep this as blinded as possible. And the prescriber's last name wasn't actually really the prescriber. I kind of kept you guys from the actual prescriber's name just to kind of protect their privacy. But once they've entered that and they go back to the main page, you'll see this has started calculating statistics for them. If you'll see down there in that first table, that gives their rates per 1,000 resident days. So you're seeing their rate for all their antibiotics, their rate for urine infections, their rate for respiratory infections, their rate for skin infections, their rate for others, and their hospitalization rate and their readmission rate. And then it's also calculating their rates per 10,000 resident days for C. diff and for MRSA. And then also showing their median days of antibiotic prescription duration. So for all antibiotics, for urine, for respiratory, and skin. You're seeing it's calculating all those statistics for them based on the data that they've entered for January, February, and March. There's also some graphs down at the bottom.
Does that happen automatically? Do they have to push a button?
Yeah, this happens automatically. You don't have to push any buttons. So as soon as you come back to that page, you're going to see that it's already calculating your graph. You don't have to do anything special. You don't have to push any buttons. You don't have to run anything. It just automatically calculates for you. And then you're seeing down the graphs down there. It's letting you know the percentage of antibiotic prescriptions for that particular infection. So for this particular nursing home, they have a lot of respiratory infections. So their respiratory infection is actually one of their highest rates. And and then their urine infections are a little bit less, and then they have about 7% for skin and 2% for other. The majority of their antibiotics were actually prescribed in their nursing home, so this tells you the location of their prescriptions. So 80% were done in their nursing home, 15% were in the hospital, 40% were in the emergency department, and 0% of those were actually done in a medical office. 4% were in the emergency department. And then you're also seeing their quarterly trends, you know, on the graph. So you're only seeing their first 3 months because that's all they've entered so far. But as you kind of go through this, you're going to actually see if you're actually getting a little bit of reduction from this. So the graphs down at the bottom will be really nice for you. So again, looking at your implementation manual, it'll be able to help you kind of walk through this, as well as I'm always here and available for help if you guys have any technical issues as you kind of start entering your data into these spreadsheets. And I'll turn it back over to Phil.
Thank you. There'll be time for questions after we're done, because I'm just going to talk for a couple more minutes. After our next webinar in about a month, that will be the time to start thinking about doing your education, and that's what we'll be focusing on next time. But you want to educate everyone. So this is step number 4 after you've got your data. Nurses, providers, supervisors, residents, and family, and we'll talk about how they all interact. Of course, you're aware that decision making in the nursing facility, it involves more people than in most other settings, because all of these individuals have something to say. So we've got training for the nursing staff, which includes a DVD and pocket cards with key guidelines, all of which we're hoping you'll hold off for until you've got your data. And we'll talk about how to implement them when we get together next. But they're here. You may want to, if you're curious, you can listen to them yourselves or look at them and make sure they work. We have posters for periodic reminders to staff, and we recommend that you don't put them all up at once, but save them so that every few months you put one up so that you can focus, 1 month maybe on urine infections, another month focus on skin infections, and that way over the course of the year you can really kind of gradually reinforce different messages. Of course, the initial education will touch all these bases. And then we have training for medical staff, and this we found was the most helpful to them was a podcast that they could put into their car, into their CD player, and listen to cases. They're all cases of discussion by experts from various disciplines about common and challenging cases around antibiotic stewardship. And then we have some pocket cards for them as well that help reinforce the kinds of things that you'll be working on as well at the nursing home level. We've never been able to figure out whether the emergency department staff actually use this, but we've made this available, and not everyone has chosen to receive it. But certainly there's a lot of concern that emergency departments overuse antibiotics, and we're hoping we've got some real nice discussions, once again, as a CD that they can play in their cars or driving around, with a roundtable discussion on 10 tough cases around antibiotic choice and some of the issues. And then this is a quite popular thing. It's an educational brochure for families. It helps them understand why an antibiotic is not a useful thing unless it's going to be useful. And we also have on our website a 5-minute video that people can not necessarily download, but at least play and watch. And I'd encourage you to find it and look at it, because it was developed professionally and really designed for consumers. And then you never know when the best time is to establish policies and procedures. There will be standardized policies and procedures. I'm working with a group that's going to publish them, but I get worried that policies and procedures get into a manual and nobody ever looks at them. So I think reviewing data and setting up your priorities may be a better first step, and then develop your procedures and policies so that they are kind of data-based and goal-based, and then they're endorsed by your staff and updated regularly. But we'll be talking about these as the months go by. So next, I'm going to turn it back to Julie to talk about the next steps, and then hopefully we'll have a few minutes for questions.
Great, thank you so much. We do have a couple of questions, so I just have a couple quick slides, and then I'll read the questions that have been submitted. And if you have additional questions, please feel free to enter those, and we'll talk through those in a couple minutes here. So today was meant to just walk through the program, the toolkit, so hopefully you have all received your toolkit. I did have a message from someone that didn't get a drive, so we'll follow up on those types of things. So please let us know if there were any issues with your toolkit. We also wanted to walk through the data, and as Kimberly mentioned, she's available for questions to help support you. We're also going to be having monthly kind of check-in calls, so there's opportunities to ask questions. So once you get started on that, if you run into issues, please let us know. So next steps for us is we're looking for baseline data, and I know some of you have started to collect that and some of you have not. So what we'd like to do is have you submit at least March and April data by June 15th. And then the UNC team is going to be analyzing that data and using that to give us very targeted information at our next webinar on June 28th. So let us know if you have any issues with that, but we would love to have, like I said, March and April, and if you can submit May, also include that data. And you're going to be submitting that to Kimberly, and her email is on the last slide here. So, and then our next session, as Dr. Sloan mentioned, on June 28th from 2 to 3 p.m., and we'll be sending out calendar invites with that information. And as I mentioned, we're going to be scheduling monthly conference calls, and I'll send out an email and get your feedback on when is the best time, or what's the best day of the week and the best time to schedule those. And those will be more informal, just asking questions, sharing information. And then I'm also going to be setting up a listserv so that you can share ideas with each other, ask questions, and Kimberly's going to be part of that. And if you don't want to be part of that, you can just select that you want to be dropped from that. So I'm going to be setting that up probably this week. And then next slide, please. And then I'm also going to be sending out a calendar of events. So it put a couple of things I want to talk about here. So I mentioned that submitting March and April data in May, if you can, by June 15th, and sending that to Kimberly. And then we're also added on here for July then to submit your data through June, just so we can kind of get on a quarterly cycle. And you'll just be updating the spreadsheet to include then the June data by July 15th. And then after that, we're going to get on a quarter calendar. So after the end of each quarter, 15 days after that, we'll be asking you to submit the data for that previous quarter. So for third quarter, you see there by October 15th to submit data through September. And then by mid-January, submitting data for fourth quarter, so through December. And then for the first quarter of 2018, submitting that by April 15th. And so we'll be updating this calendar periodically as new things come up, but just to give you, put everything in one place so that you have that. So I think that's my last slide. And then also at the top, you'll see if you could de-identify your antibiotic list that you're sending in and taking the resident name off before you send that in, that would be great. So we do have some questions, and I'm going to walk through these here. There's a lot of data questions, which is, I'm not surprised. Can you go up there a little bit? Okay, so I went through those. Okay, so a couple questions. So I have a resident developing ESBL in urine. Can that be added to the spreadsheet? Most C. diff that I'm seeing is coming into the facility from the hospital. How should that be documented? I think that's a question to Kimberly, maybe.
Well, ESBL is certainly one of the key targets in terms of infections that we want to prevent. We chose not to get into asking you to document urine culture results, which is really what you're talking about, because it gets more complicated. But if some of you want to do that, we can certainly add that in a, because it's something that we kind of think of it as the second level of data. I don't think CMS is initially going to ask for that. They're going to ask for the kinds of stuff that we're presenting here, but we are very interested in that. In order to do that, I guess we have to ask, what is the question you want to ask? You know, if you want to document that it's there, then you probably want to look at every urine culture that you order and see what the rate is and how often you've got ESBL positive cultures. And the rates, you may be surprised. Hopefully they're pretty low because they usually are in most nursing homes.
And to answer your other question about the C. diff coming from the hospital, when you mark that in your spreadsheet as an other and then give it a specific diagnosis of C. diff, you also be putting where it was prescribed. So that'll kind of get at that hospital and C. diff. And if you guys, as we do these monthly check-in calls and as you're submitting your quarterly data, we could probably do some specific stuff to how many C. diff diagnoses are actually coming from the hospital.
Yeah, I think, but it is interesting because, each of your, some of you may have real specific targets that we're not specifically targeting, and they want to add some extra things. For example, if you look at the data on C. diff, something like, and we'll go over this in June, a reasonably high percentage of C. diff cases arise within 28 days of a hospitalization. And then it begins, and then the next highest rate is within the next 28 days. And so if you want to look at your C. diff cases, there's some other things you can do around tracking them, but it would be kind of an extra type of thing. But if some of you want to look at that or want to look at the ESBL resistance, do it. Because they're really getting into, you're talking about some of the kind of hot issues that are kind of above and beyond some of the basic stuff we're talking about.
Okay, great, thank you. And then the next question is, Minnesota would like us to monitor non-antibiotic illnesses also. Would this be able to meet that requirement?
Could you say more about that?
And I'm not sure, to be honest.
Yeah, this is a can of worms because, theoretically, what we would like to do is know whether there are illnesses that are not being treated, because that's really the only way to have a better idea on whether your prescribing is kind of appropriate or not. And the thing about it is, it's so hard to get that. So if Minnesota really wants you to do that, wow.
Yeah. Okay. No, and we
might want to have a committee, a subgroup to actually talk about how to do that, because we've spent a lot of time struggling with that. And what you want to do is have a consistent, essentially a consistent standard for defining when somebody has an infection. And I think if you can come up with that, then you've got something. But for example, let's say it's a winter time and 20% of your people are coughing, and a cold has gone through your facility. Well, those are all infections. Really, they're viral infections, and so does Minnesota really want to know that? And if so, you want to make sure that you don't look bad because you've done a really good job of documenting your respiratory infections compared to somebody else. Although, on the other hand, infection control practice means that you want to minimize spread of respiratory infections, even when they're viral ones. So it's an interesting topic. It's not something we are addressing because it's not directly. It's more indirectly about stewardship.
No, that makes
if you
sense.
have to do it, we probably should have a group. The first step would be to see what exactly they want to know, and then come up with standards. And then what we would do is we would amend the Excel spreadsheet to have you list the untreated infections on it as well. And
okay. No, thank you. We will follow up
creates
on that.
a huge burden. A huge burden.
Okay.
You know, for example, somebody's got a localized, infection. They've got a wound with some redness around it, and it's probably, not a systemic infection. Maybe they've just got some colonization. Do you put that on the list or not? Y'all have some tough questions. Really.
We're very detail oriented here, so no, we'll follow up on that on our side here. So thank you so much, and I really appreciate the fact that it sounds like you're very flexible, and if new things come up and it makes sense for us to track those, that the program is flexible enough for us to do that. So I think that's great.
Well, we have to meet your needs. If we're not doing that, then we're not doing what we need to do.
I appreciate that. Okay, so here's another data question. Do we count antibiotics for separate months if the antibiotic for a separate month if the resident is treated for the same infection for 2 months? So if they're still on the same antibiotic for the same infection over 2 months.
Yes, if they're on a new antibiotic, unless you counted it, say they started on it in March, and you put the duration down as 60 days when you recorded it in March. You don't need to include that again for the next month of April.
So if it's a new prescription.
Right, if it's, yeah.
But if somebody got a prescription today, which obviously will go into June, you just record it once.
You just record it once, right.
On the day it was prescribed.
And then the duration. Okay. That makes sense. Thank you. If an antibiotic is discontinued, do we count just the days that the med was given or how long the med was ordered for?
Just the days given.
Yeah, just the days given.
Okay, so the actual days. Okay. And how do we count?
That will happen sometimes. Yeah.
Where do we count hospice in our census?
We haven't included that. Is there a reason you'd want to include hospice?
So you're not, that shouldn't be included in the denominator.
Oh, sure. If people are on hospice, they're still nursing home residents, sure.
Okay.
But you would just count them as your long stay residents.
I mean, people on hospice get antibiotics. People on hospice have infections. People on hospice, really, they face the same thing. Now, there is some value in looking particularly at, and when we've drilled down in some of our research, we've looked at people in hospice to see, do they have a do not give antibiotic advance directive, and if so, did they get an antibiotic? Because of course that's probably not appropriate, although usually it's a qualified thing, and so if there's a specific, I'd be interested in knowing what specific reason. In general, we're not asking about hospice. It's usually a relatively small number of folks, and they're often treated pretty much the same way when it comes to infection management, because most people in hospice can get antibiotics unless they are very terminally ill, which is kind of one of the things we encourage people to do education about.
Okay, so we have time for maybe another question. Otherwise, we'll follow up for those that submitted the questions and make sure that we get your questions answered. The next one is the easy one. I can do that one. Is the June 20th training the webinar? Yes, it is. So I've got, and then this one last one here. Should we not report prophylactic antibiotics?
Yeah, you should include prophylactic antibiotics, but you'll just mark them as other.
And then write in why.
Yeah, and write it, if it's a UTI prophylactic, write that in, or if it's for dental, make sure to put that in the other column.
Okay. Okay.
And that's important because some type of preventive antibiotics are falling out of favor these days. And so it's worth looking at.
Okay. So we're out of time, but there's a few other data questions. So like I mentioned, we will get those answered, and we'll send them out broadly to the group too if it seems like a question that would benefit the full group. And as I mentioned too, please follow up with us if you have questions. And then there's a question, how do we download these slides? So we'll be sending out the slides along with the recording. If you have others within your organization that you want to listen to the session today, so those will be available today or tomorrow, probably tomorrow. Yeah, tomorrow. And then, like I said, any questions, our information's there. So general collaborative questions, please send my way. Data and practice questions you can send to Kimberly, and she will also send questions that are appropriate for Dr. Sloan to Dr. Sloan. So thank you everyone so much for being on the call today and being part of this collaborative. I hope you this gave you some information to get started. Much more to come, and again, thank you so much for joining us and have a great evening. And thank you, Kimberly and Dr. Sloan, so much for your time today and sharing your expertise with us.
Thank you.